Respected doctors, on behalf of JIP Academy, I welcome you on this program. So, each and every week, we are trying to cover one common topic. In this way, this week we are going to cover hypotension. Last time நான் இந்த ஒரு ப்ரோக்ராம்ஸை போடும்பொழுது யூடியூப்பில் சார் கொஞ்சம் நீங்கள் தமிழ்லேயும் ரொம்ப கொஞ்சம் எமோஷ்னலாக பேசுங்க சார், அப்போ தான் இன்னும் நல்லா எல்லாம் மனசில் பதியும்னு சொன்னாங்க. ஸோ ஓகே, ஸோ ஐ அக்ரீட் ஃபார் தட். தமிழ் அண்ட் இங்கிலீஷ் நம்ம கலந்தே நாம் இதை பண்ணுவோம். ஸோ how will you define hypotension? So hypotension is defined as when systolic blood pressure goes below 90 milligram, that is called hypotension. So when systolic blood pressure goes below 90 mmHg, that is called hypotension. But you have to remember that many young female, they used to maintain systolic blood pressure of around even 80 without any symptoms. So I could say it is a very arbitrary definition, but somebody is presenting with blood pressure below 90 mmHg with the symptoms of giddiness and sweating, then definitely you have to think of hypotension. Then more than the systolic blood pressure, what we are worrying about that the mean arterial blood pressure, that is called MAP, mean arterial blood pressure. So how will you calculate mean arterial blood pressure? So take diastolic blood pressure plus 1/3 systolic, 1/3 of difference between the systolic and diastolic. For example, somebody is maintaining blood pressure of 120/80. So what is their mean blood pressure? So diastolic blood pressure. So here diastolic blood pressure is 80, okay, plus the difference between the systolic and diastolic. So 120 minus 80, 40. The 1/3 of 40 is somewhere around 13. So 80 plus 13, 93. So that is mean arterial blood pressure. This mean arterial pressure reflects the organ perfusion. That's the way it gains very important. Or otherwise, hypotension could be defined in such a way that somebody's blood pressure is falling around 30 mmHg from their baseline. That's also we used to call hypotension. For example, my blood pressure is around, normal blood pressure is around 130. Suppose now 1 hour before 130, then within an hour 30 mmHg is coming down from this 130, then it is also called hypotension. So basically, what are the causes of hypotension? So hypotension can be broadly classified into 3. I could say 4. One, hypovolemic hypotension, and second one, cardiogenic hypotension, and third, septic shock hypotension, and anaphylactic shock. So what are the 4 causes of shock broadly? 1, cardiogenic shock, and hypovolemic shock, anaphylactic shock, and septic shock. So generally, so whenever we face a person with the blood pressure below 90, we will be tempted to give 0.9% sodium chloride. So just சொல்லுவாங்க, எனி ஜென்ரல் ப்ராக்டிஸ் யாராவது பிபி ரொம்ப லோவாச்சுன்னா உடனே ஒரு என்எஸ் போட்டுருங்க அப்படின்னு சொல்லுவாங்க. ஸோ வெல் அண்ட் குட். ஸோ என்எஸ் கேன் பி இன்ஃபியூஸ்ட் as much as possible in all other types of shock except cardiogenic shock. இந்த cardiogenic shockல மட்டும் நீங்கள் நாமசலினை ரஷ் பண்ணும் பொழுது patient may go for pulmonary edema. So my humble suggestion would be, first any patient who presents with blood pressure below 90 with hypotensive symptoms, then you try to rule out first cardiogenic shock, because even septic shock may require 0.9% saline. Even hypovolemic shock, vigorous replacement may be required. Even anaphylactic shock, 0.9% saline may be required, but cardiogenic shock, it may be contraindicated. So when you approach hypotension, first you try to rule out cardiogenic hypotension. So generally cardiogenic hypotension, they will present with either florid pulmonary edema. So somebody is presenting with crepitation all over the chest with the blood pressure around 80. So probably the patient is in pulmonary edema. Indirectly, it is suggestive of cardiogenic origin. So this patient may require ionotropes rather than 0.9% saline. So this patient deserves vasopressor, and you have to find out the cause for cardiogenic shock, and according to that you have to treat. So any patient who presents with shock, first you try to elicit the history aligned with cardiogenic shock. For example, whether you have chest pain or any breathing difficulty, any history of coronary artery disease, any history of valvular heart disease, or any history of structural heart disease, you try to rule out cardiogenic shock at any cost. If possible, apart from the history, take an ECG quickly. ECG may show the evidence of old MI or any newer onset of MI, or a patient may have valvular disease like left ventricular hypertrophy, left atrial hypertrophy. So these are the signs may be elicited from the ECG. So once we elicit these signs from the ECG, then patient can be subjected to echo. Echo will tell us the LV function. Suppose LV function is 30%, 40% EF, then probably your judgment may be right. So once again, I want to insist that any patient who presents with shock, you try to rule out cardiogenic shock by taking history, doing ECG, and taking echo. So once you rule out cardiogenic shock, then probably 0.9% saline can be given. But you have to find out the cause for shock generally. Suppose then next, once you rule out the cardiogenic shock, the remaining three would be septic shock, anaphylactic shock, and hypovolemic shock. This anaphylactic shock, somehow you can easily assume. See, there will be some history of exposure to antigen. For example, that's antigen may be a IV drug administration. So as soon as patient receives penicillin or cephalosporin, even insulin also. So I had very bitter experience some 7 years before when I tried to demonstrate insulin injection. So as soon as I gave 5 units of insulin, patient developed breathing difficulty and blood pressure suddenly fell down. So what I want to insist that anaphylactic shock, they will give some history of exposure to a antigen. That the antigen may be IV drug, as I told you, maybe food, sometimes non-vegetarian food like fish, crab, prawn, and so on, or sometimes even radio contrast material. And there are so many causes for anaphylactic shock. So there will be a particular exposure to antigen will be there. And second one, they will have breathing difficulty. You may find some wheezing on the chest, and the blood pressure may fall very quickly. And third one, there may be some choking in their throat. There will be persistent clearing of the secretion, like along with breathing difficulty, they used to do something. They will do like that. So this definitely may point out that you are dealing with anaphylactic shock. So anaphylactic shock, what happens? Once the antigen is exposed, then automatically once our mast cells releases histamine and leukotrienes and so many inflammatory mediators. So this histamine causes enormous vasodilatation. This otherwise called distributive shock. What they are telling, all the blood will be pulled into the venous system. See, venous, the veins are able to dilate 30 times as much as arteries. So when veins are dilated, all the blood will be pulled in the venous system. So there won't be any venous return to the heart. So naturally cardiac output would be low. So they develop hypotension, and this leukotrienes causes bronchoconstriction. So simultaneously they will have hypotension and breathing difficulty, some kind of chest tightness and auscultation wheezing. So this is clear cut of anaphylactic shock. So generally when somebody is having anaphylactic shock, we will be always prepared to give steroid and antihistamines. But please remember that the drug of choice for anaphylactic shock is adrenaline. That is 1 in 1000 adrenaline. 1 in 1000 adrenaline, 1 ml should be given. Either it can be given IM or subcutaneous. somebody is brought with the history of anaphylactic shock with the blood pressure of 80, 70, breathing difficulty, without giving adrenaline, don't refer the patient, because on the way patient will collapse and they will die. So, it is imperative to give adrenaline. So, as a general practitioner or tertiary care level, you don't need to hesitate to give adrenaline. That's my humble request. You don't need to give IV. IV means you have to dilute like 1 in 10,000. At least you can give IM, that is 1 in 1000 adrenaline 1 ml. So, we have to keep always adrenaline. So, in our dispensary or even a small clinic also, wherever you practice, because it is a very life-saving one. So, what happened? This enormous vasodilatation will be converted into vasoconstriction when you give adrenaline. That's the purpose of giving adrenaline. So, this steroid and the antihistamine may be useful in preventing the relapse. It won't be very useful in the case of anaphylactic shock. Anaphylactic shock, you have to give adrenaline. And is there any investigation to prove that we are dealing with anaphylactic shock? Generally, it's a history and a clinical features generally, but they are stating that you can do tryptase in the blood levels, because mast cells, basophils release tryptase. So, this tryptase will be elevated in the blood. When you check the tryptase, if it is elevated, that means you are dealing with anaphylactic shock. So, this is anaphylactic shock over. Then another one is septic shock. So, septic shock also the management. So, here also a patient can be given 0.9% sodium chloride. But in the septic shock, there is combination of pathophysiology is getting operated. One, apart from this hypovolemia in septic shock, there is enormous vasodilatation, something like anaphylactic shock. Here also vasodilatation all over the body. That's why many of the septic shock patient, initially their skin would be warm, very warm, because the superficial cutaneous vasodilatation anywhere. So, we used to say it's a warm shock. So, in septic shock, initially they will be warm because of enormous vasodilatation. At some period of time, there will be myocardial depression in septic shock. So, in septic shock, what happened? One area vasodilatation and another one myocardial depression, and because of capillary leak, there will be hypovolemia. So, what happened? This patient deserves, apart from 0.9% sodium chloride and vasopressor. And generally, how will you identify septic shock? I come across many of septic shock patients having missed by general practitioner. So, when will you suspect septic shock? See, somebody who presents with fever, okay, 102, 103, or history of fever 2 days before or 3 days before, then if they develop dyspnea, okay, so the earliest symptom of sepsis would be dyspnea, that you should remember. So, if respiratory rate is more than 22, 24, 25 in the presence of fever, or with the past history of fever 2 days before, then you have to suspect sepsis. So, any patient history of fever in past couple of days with dyspnea, definitely you have to think of sepsis. Then how will you confirm further? So, probably when they have dyspnea, if you auscultate, suppose if the infection originating from any other source other than lung, most of the time there won't be any lung signs. Okay, for example, urosepsis, they will have a history of urinary burning sensation or fever, chills and dry hair. Maybe tachypnea may be there. If you auscultate, so the lung signs may not be there, like biliary sepsis or wherever sepsis, even the skin infection that causes cellulitis followed by sepsis. These kind of patient, they will have normal lung signs. So, there may be hypotension, but there may not be any lung signs. History of fever will be there. And if you check some blood test investigation, for example, the count, total count may be very much elevated, or another extreme, there may be leukopenia. So, leukocytosis or leukopenia may be there. Then you can do few biochemical tests also will be helpful. Do procalcitonin. If procalcitonin is elevated, then probably you can strongly suspect the patient is in sepsis. So that's very, very important. So that's why you have we used to say SOFA score. So SOFA score means sequential organ failure assessment. So in the guidelines, any patient who presents with septic shock, they used to assess PaO2 by FiO2. That's for lung. Is there any the ratio is 300 or 400? Check bilirubin level for liver, SDOT and STPT, and check urea and creatinine. So septic shock, no, ultimately they will go for multi-organ failure. So how you can suspect septic shock? Any history of fever present or the past history for a couple of days with hypotension and increased respiratory rate, then think of septic shock, then elaborate according to that. So this patient may respond to 0.9% saline and vasopressor, then you have to treat the source of infection, that is septic shock, over. Then hypovolemic shock. So what do you mean by hypovolemic shock? So hypovolemic shock because of loss of intravascular volume. Okay. So hypovolemic shock, the history is very, very important. For example, there may be history of 20 times, 25 times diarrheal episodes in a day, or vomiting, or burns, or hypovolemic shock secondary to blood loss. For example, trauma or obstetric procedure like abruptio placenta or postpartum hemorrhage. So what happens? Your intravascular volume decline. These patient also will respond to IV fluids. So hypovolemia can be treated by both crystalloid and colloid. What do you mean by crystalloid? So crystalloids are, these are crystalloid. We used to say 0.9% chloride and ringer lactate, 5% dextrose. These are crystalloid. Routinely we call it as an IV fluid. So another one is colloid. Okay, that's a brand name, Himachal is there. So these are colloid. So both crystalloid and colloids can be given to increase blood pressure when you suspect hypovolemic shock. Okay. So what is the difference between this crystalloid and colloid? What is the advantage of colloids over the crystalloid? So this is 0.9% sodium chloride, ringer lactate, all I have told is crystalloid. So basically, when you infuse normal saline, okay, when you infuse normal saline in a person, if you infuse 1 liter of normal saline, it has been estimated that only 250 ml of normal saline will stay back in the intravascular volume. So intravascular compartment means here blood vessel. So you prick, then you are giving normal saline. If you infuse 1 liter normal saline, only 250 ml will stay back inside the intravascular compartment or inside the blood vessel. Remaining 750 ml will be getting into interstitium compartment. So somebody is losing 1 liter of water from the body. If you replace with 1 liter of normal saline, only 250 ml will enter into the intravascular compartment. So that is a small disadvantage of this crystalloid. So what about this colloid? So this colloid is a larger molecules basically. The particles that are present in the colloids are larger molecules. The advantage of this colloid, if you infuse 1 liter colloid, the same 1 liter will stay back inside the intravascular compartment, inside the blood vessel. It won't extravasate into the interstitial compartment. Did you get my point? So if you infuse normal saline, if you infuse 1 liter normal saline, only 250 ml will stay back. 750 ml will get into adjacent interstitial compartment. Outside the blood vessel, it will enter. But if you infuse 1 liter colloid, the entire 1 liter colloid solution will stay back inside the blood vessel. Apart from that, because of this high osmosis, because when molecular weight is high, naturally your osmolality also will be high. So what happened? This 1 liter colloid will drag some amount of fluid from the adjacent interstitial compartment. So if you have colloid, somebody is having GI bleed, for example, hematemesis or melena or a traumatic shock, blood pressure is 60 or 50. If you keep colloid, this colloid can be given over 1 hour or 2 hours. So what happened? If you infuse 1 liter, that 1 liter, entire 1 liter will stay back in the circulatory system. Apart from that, it is able to bring some more fluid out of the blood vessel and it brings into the blood vessel. That is the advantage of colloid, but it is costly. sometimes it itself may produce some allergic reaction. That kind of hesitancy may be seen among the general practitioner. But as I told you earlier, like adrenaline, better to keep on colloid in your pharmacy also. So when patient presents with hypovolemic shock, definitely you can give colloid along with 0.9% sodium chloride. It is very, very useful. But the most important thing is uh, when somebody presents with a hypovolemic shock below 80 or 70, 0.9% normal saline would be the best fluid of choice. The ringer lactate, the next choice. First, normal saline would be the best choice. Then 5% dextrose is absolutely contraindicated in hypovolemic shock. So we have very valid medical reason why you should not give ringer lactate when somebody is presenting with 60 mmHg or why 5% dextrose is absolutely contraindicated in hypovolemic shock. It is out of scope of this program. So probably you can contact me personally. I am ready to explain. And how will you suspect hypovolemic shock? So naturally history, and second one, they will have cold clammy skin. Like septic shock, they will have warm skin. Here cold clammy skin, and they will have giddiness and dryness of skin. Okay, the poor skin turgor and dry tongue and orthostatic hypotension. So their BP may be 90 may be there. If you check in the supine position, it will drop further. There may be evidence of orthostatic hypotension. And even biochemically also hypovolemic shock you can differentiate. Disproportionate elevation of urea and creatinine. Urea may be like 90, 92, but creatinine will be 1. So when urea is alone is elevated, but creatinine remains at normal level or slightly higher, then it is called the disproportionate elevation of urea creatinine, very much future of hypovolemic shock. So the drug of choice for hypovolemic shock is 0.9% and if possible colloid in many occasions, and you have to treat the cause for hypovolemic shock. So I think that with that I sincerely hope I have briefly explained about shock. So the take home message would be, whenever somebody presents with blood pressure below 90, systolic blood pressure 90, you consider this a hypotension unless otherwise proved. Always to rule out cardiogenic shock by carefully auscultating the lung for lung signs and take ECG and echo. Once cardiogenic shock is ruled out, then you can liberally give 0.9% sodium chloride. Please think of anaphylactic shock, which deserves separate treatment like adrenaline. And if patient gives history of fever, then additional findings of leukocytosis and early dyspnea without any lung signs, think of anaphylactic shock. So with that, I want to end this program. I sincerely hope I throw some light on this topic, hypotension. Thank you.